We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Good afternoon, everybody. It's nice to see you here. Welcome to the people who are online as well. My name is Amy Salmon, and it's my pleasure to welcome you today to our Center for Advancing Health Outcomes Work in Progress talk. Today, we're very pleased to have Dr. Roxana Geoffrion here, who is going to speak on the topic of surgical competence evidence to implementation. Before we proceed, I'd like to acknowledge with gratitude that our meeting today is taking place on the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'd also like to welcome Dr. Geoffrion and share a little bit with you about her background. So she is an associate professor at UBC and has a full-time practice in as a urogynecologist at the Center for Pelvic Floor at St. Paul's Hospital here in Vancouver. Dr. Geoffrion completed her medical degree at McGill University and her residency in obstetrics and gynecology at the University of Ottawa. She then pursued subspecialty fellowship training in female pelvic medicine and reconstructive surgery at the University of Calgary. She's the director of the UBC Urogynecology Fellowship and the head of the Obstetrics and Gynecology Residency Research Committee. Her research interests include surgical education, evidence-based patient education, and knowledge translation in the area of pelvic floor health through whiteboard animation, as well as surgical outcomes and sexual health of patients with pelvic floor disorders. She holds competitive grants from the Canadian Institutes of Health Research, the Women's Health Research Institute, and Health Research BC. Dr. Geoffrion is the current president of the Canadian Society for Pelvic Medicine and the national organization dedicated to pelvic floor health in Canada. Please join me in welcoming Dr. Geoffrion.
All right, can you all see me and hear me well? I definitely will not be sitting behind the podium here, then I will disappear. But thank you very much for the kind introduction and for inviting me to talk to you guys about a topic that's near and dear to my heart here and showcase our work over the past decade really in surgical education. And not doing this right. I don't have any disclosures. This work was funded at the very beginning by a competitive medical education research grant from the Royal College of Physicians and Surgeons of Canada. Have you guys ever wondered, what does it take to train a surgeon? And not just a surgeon, but a competent one. So today, my objectives are to discuss with you some relevant skill acquisition theories, as well as to tell you a little bit about our work in validating low-fidelity simulation to teach vaginal surgery to residents, and also to talk about assessment tools that we're trying to create through this project so we can be in line with the Royal College's mandate to implement competency by design. So how do we become experts? It doesn't have to be in surgery, but in any sort of skilled profession. We start out as novices. And at that time, rules are very important. They're our safety network. So we rely on rules. And if anybody tells us deviate from that rule and do something different, we immediately feel not good. And so as we advance in knowledge, skills, and attitudes, we become more proficient and eventually, hopefully, experts. And by then, rules are internalized. So we don't dedicate as much mental space to rules anymore. We just do things automatically and can focus more on the patient holistically. So what is the intended outcome of the surgery? What is important to this individual person in particular? And how can we make that happen in a safe and efficient way? And at the expert level, we're actually having a lot of trouble deconstructing our analysis and procedures into smaller steps for learners. We have a lot of trouble explaining why did we make that decision in that particular moment, because honestly, we don't really know. It's just our training that prepared us for that moment. So how do we get a surgeon from novice to proficient and expert through residency and beyond? Well, this is done in several ways in different jurisdictions. So for example, in the US, we've got the ACGME, which stands for the Accreditation Council of Graduate Medical Education, and they rely on numbers. So if a resident performs 15 hysterectomies, so this is an example of gynecological procedures. For those of you who are not clinicians, a hysterectomy is the removal of the uterus for whatever indication. And the safest, most effective way and the best way for patients is, if possible, to perform this through a vaginal approach. And and I just remembered, I'm so sorry, Sean, I completely forgot to mention, there will be 1 or 2 surgical images. So I'm hoping that you guys won't be too put off by this and walk out all en masse. But anyway, so vaginal hysterectomy is a safe, efficient way to remove the uterus. And the ACGME says a resident has to perform 15 such procedures in a competent manner to be able to graduate, and 15 more abdominal hysterectomies, and 15 laparoscopic hysterectomies. But what you need to understand is that vaginal surgery over the past maybe 2 decades has, although it's the best, and everybody recognizes this in this profession, it's sort of been neglected in the interest of newer techniques like laparoscopy or robotics or something else. And so vaginal surgery skills have declined, and also resident work hours have also declined. And so exposure to these procedures is not as good as it was 20, 30 years ago. In Canada, the Royal College has come up with entrustable professional activities, which are to be essentially gained through residency, and they encompass the meat of our specialty. So, you know, there's an EPA for giving bad news to a patient, or another EPA for individual surgical procedures. So these EPAs, specified knowledge, skills, and attitudes, can be independently executed, are observable and measurable, and encompass a set of competencies. But you can imagine that for something like internal medicine, where you need to give off the differential diagnosis of fever, and compare that to a surgical procedure like a vaginal hysterectomy, where we don't really have assessment tools, it's very tricky. So, as an example, for performing major vaginal and vulvar procedures in gynecology in Canada, they also rely on subjectively observed procedural skills by skilled surgeons who supervise a resident in the operating room, as well as a logbook with numbers, again, of procedures. And so for vaginal surgery, they have to be doing at least 1 vaginal hysterectomy competently. Now that can be interpreted in a number of ways. It could be 1 vaginal hysterectomy altogether for residents to graduate, or it can be more. It's left to interpretation, and there are no good assessment tools. Now this, as you can imagine, creates a problem. So residents in OBGYN spend 5 years learning the different procedures of the specialty. And on June 30th, 2024, there will be 8 residents graduating, and they'll be fully licensed to practice OBGYN. And at that point across Canada, 69% of them and 90% of the residency program directors will say, yes, I can do a vaginal hysterectomy. July 1st, 2024, when they enter a fellowship, such as female pelvic medicine and reconstructive surgery, where they learn more surgical skills, their program directors state that only 20% of them, so only 1/5, can actually independently perform a vaginal hysterectomy. So it's a huge disconnect, and perhaps we can do better at educating them. So what is expertise? This is Dr. Erickson. He's an eminent psychologist who dedicated his life to the study of expertise. And he says that to gain expertise, you need something called deliberate practice and good quality available training resources. So according to him, if we have the resources and the tools, and if we can convince these individual residents to practice, with deliberate practice, then they'll be fine. So expertise is somewhere at the intersection of time, motivation, and deliberate practice. And deliberate practice is hard. So it involves painful self-assessment, a coach, mentorship, daily dedication to practice. And as you may know, the 10,000 hours rule. So this is Malcolm Gladwell. He publicized this psychological phenomenon and said that if you look at any kind of cognitively complex field, from playing chess to being a neurosurgeon, if you practice for 10,000 hours, which is roughly 10 years of 4 hours a day, you'll be fine. So any child with a tiger mom in the audience knows that this is no joke. And so as trainees, do we spend 10,000 hours operating? Well, we did the math. So in general surgery, we actually spend, so residents, I should say, spend 3,963 hours actively operating, or 1/5 of 5 years of 80-hour weeks. And in gynecology, they spend about half of that because they have to also learn how to deliver babies and take care of pregnant moms. So half of their time is spent in obstetrics. So we can't do it. We can't do the 10,000 hours during residency. This is from the Royal College, where again, you see that novice to expert on the y-axis. And then on the x-axis, you see the first part, which is training, right? And then you gain, so you go through training, which is residency, and then there's deliberate professional practice. And then, during that time, a practicing gynecologist may not do a certain type of procedure. So they fall off the competent curve and into this area the Royal College defines as discompetence. Their word, not mine. And so, it requires maintenance of skill. So more deliberate practice at this point. But how do we do that? Well, in laparoscopy, there's this thing called Fundamentals of Laparoscopic Surgery, which is essentially a very well-validated model to teach basic laparoscopic skills to residents. And this has been implemented over the past 30 years in all residencies across Canada and the US for general surgery. All residents have to pass this. And it involves, so this is low fidelity. So for those who don't understand the difference between low and high fidelity just means that it's not the real OR environment. It's just basic skills and very basic tools. And, the residents learn skills such as cutting a circle with a laparoscopic instrument on a cloth, or peg transfers. And this helps them in the actual OR. Now, there are a lot of models like this, but this is the only model in the history of surgery that's been demonstrated to have transferability of skills, which means you're going from practicing on this low fidelity and having a pass-fail score. And if you pass, you will have, research has demonstrated through randomized controlled trials, better skills as an operator on actual patients. So this is important because it's okay to play in a room, but does that make you a better surgeon, really? And this is the crux of it. There are a lot of models that exist. So this is just for laparoscopy, but what about vaginal surgery? This is a very expensive tool called the Miyazaki model of vaginal hysterectomy. And so they designed this, bracket, and then there's a uterus in there. And then, the procedure gets performed. And right now with their publications, so you can actually see the setup, you're taking the uterus out through the vaginal opening, and it's all sort of plastic and silicone and actual instruments that are used in an actual OR to do this procedure. So this would be considered a more high fidelity. So you can also maybe do this in an actual operating room with an anesthetist there and recreate some sort of, anesthesia emergency to better simulate an actual procedure. And this would be a more high fidelity model. However, look at the cost. So the cost of such a uterus, the entire model with a full set of replaceable parts, and that does not include the instruments required to operate, is US $6,700. And then that's just the model. And then you have to have the parts onto it as well. So the uterus, I don't know what the premium, so premium vagina costs $270 and the premium uterus $170. So really in Canada, we could never afford this in residency. That's just, not going to happen. And then, if you're thinking that these residents should take it home and practice, it's not going to be feasible. Oh, I'm sorry. And then I was going to tell you that this is their publication. And at this point, they haven't shown that working on this model increases skill in the actual operating room, but rather they're just on the validity where they're establishing validity between different operators. So they're showing that, junior operators versus more senior operators have better skills on this particular model. So they haven't shown transferability of skill to the real operating room. Enter Promote. This is our own project here locally. It stands for Procedure Specific Modular Training and Evaluation. It started approximately in 2012, believe it or not. And it involves both didactic and practical components. So we started with content and had this didactic content put online And as you can see, it's a module that's procedure specific. So for vaginal hysterectomy, it takes residents through perioperative considerations, through anatomy, through different types of local anesthetics to use, and a lot of things that you need to know to perform a vaginal hysterectomy. And so residents do a pre-test of knowledge, and then they do a post-test of knowledge. And if they pass, there's a passing grade on that multiple choice and short answer quiz. They go on to practice on models. And these are our models. So as you can see, they're very simple. This is not for hysterectomy, but it's for posterior and anterior repair specifically. These are old instruments that have been discarded from the operating room. And you've got silicone skin and sutures and balloons, and the balloons want to recreate the bladder and the bowel. So you can imagine that resident comes in and has to actually suture the foam without tearing the foam and without puncturing the balloon, so without entering the bladder or the bowel, in other words. So very simple sort of models with low cost. And this is for vaginal hysterectomy. You can see that there's a pole, a wooden base, a clamp that attaches the whole on the table, a cylinder, so you can vary the length of the cylinder if you wanted. There's a skewer. There's some more silicone skin around the foam, and residents learn certain skills on how to operate in a deeper space, how to take pedicles, how to pass sutures in a deep environment like this. And then at the very top, you see that the uterus has been removed and they have to suture the top of the vagina silicone skin to demonstrate that they can do it in a deep space. And they learn knot tying, handling of various surgical instruments to this, and so on. So very basic skills, low fidelity simulation. These are some of the instruments we use: a clamp, wooden base, pipe, cylinder brackets, elastic bands, and so on. And what's probably the most expensive part is the surgical instruments and sutures. So through that, we do have quite a few publications from the project. And I think the sort of cherry on the sundae is the top left one, where we finally did publish our randomized controlled trial results back in February of this year. I will show you some of our methods and results that we've achieved over the years. This is one of our star residents. He has he's modeling a type of accoutrement that is essentially, you have a camera and a light, and then he's supposed to do the surgery. So for many of these residents, we actually videotape them because they had to be assessed. And so the videotaping was done while concealing their identity, obviously. So first, we established face and content validity through a group of experts who got together and decided that the skills we were teaching encompassed the full set of skills that are needed for these procedures. And then we went on to establish inter-rater reliability. So for each resident that was videotaped on these procedures, they had two staff persons that were blinded to the resident identity and to the resident sex as well, give us the scores. And the score that we have for these models are time and errors. And we did establish adequate inter-rater reliability, and as well as good internal consistency between the items that we were trying to evaluate. And then we also videotaped medical students, residents, and attending staff and fellows who obviously know how to perform this procedure. And we established that there was a net difference between their performance on these models, thus establishing construct validity. Through all this, I learned a lot as a surgical educator. I really set out with the idea that, okay, it's give them the tools, make them practice, and be a tiger mom at work, and it'll just be fine. But it doesn't pan out that way. These are adult learners, and they all have different learning styles. So I had to go back to the psychology literature through all this because something didn't make sense. There were some who practiced too long. I would tell them, because they have to practice on the models, and then I would tell them, and not just me, it was 3 different university centers, you're ready. You're passed. You have all the skills necessary. You can now go operate. Just go try it out. You're going to be supervised. Don't worry. And still they would want to do more. But can I take the model home again? And can I do again? Others would be like, nah, I don't want to do this. This is just, too labor intensive. I don't think I need this practice. Let's just, try it out. So then I went back and does practice really makes perfect? Why do we need so many more hours for some and so few hours for others? And so this particular systematic review was published in 2014 by McNamara. And it turns out that for repetitive skills like running, performance, it can be explained by deliberate practice to a greater degree than for complex professions. So if you look at the complex professions, like aviation engineer or insurance broker, performance can only be explained by deliberate practice in less than 1%. So really, deliberate practice doesn't work that well for complex tasks, such as perhaps surgery. So then I went back to, okay, what about the different learning styles? Well, some residents are quick starters. They just want to get in there and try it out, trial and error. I'm going to do this. I know how to do it. I'm good. I don't need practice. Then there are the fact finders. How do you know these models work? Did you have any research? I mean, no, this is the point of this project. You're helping us, follow throughers. Those are the ones who take the models home 15 times and they still don't feel ready. Quite low self-confidence. And then there are the implementers who are trying to improve on the models. Well, what about adding a fibroid to the uterus? Wouldn't that be better? It's going to make it harder. Or let's make the cylinder longer to make it deeper. Or how about, trying to sort of improve on the model? And, all of that's very nice. We have to stay standardized for the duration of the study to show some improvement. We can't really modify it halfway through. So motivation from learner to learner is very, very different. And it's crucial to actually acquiring these skills in the lab. So as surgical educators, we can only hope that we can give some direction to these residents. We can encourage persistence and cultivate energy. And through that, I'm very interested in self-confidence in learners and operators and surgeons in general, because we do find that overconfident, not good. Underconfident, a pain. Just the right level of confidence is great, but again, how do you cultivate that through, learning in a surgical lab in a safe environment? So in essence, we really do need both formative and summative feedback types. We need somebody, some coach, some mentor to sit down with these learners individually and give them constant feedback on many different levels of different types of performance. And summative to finally say, okay, this is the end of the road test. You have passed. This is the pass-fail score. Research has shown that now you are ready to operate. So we really wanted a pass-fail score. And that's what we did achieve that by, again, filming a whole bunch of medical students, 50 to be exact, before they had any surgical experience and didn't know if they wanted to become surgeons or internists. And then we also filmed, like I said, fellows and very well-trained surgeons in the performance of these procedures. And you can see that where the lines intersect there, that would be sort of the passing grade of the score. And again, the scoring that we use for the models is not scoring that we use in the real operating room, but rather a scoring that was devised specifically for the models. And it includes timing and errors. So subtracting elements if there are errors that are predefined. So we have these pass-fail scores now. And again, this project didn't only involve vaginal hysterectomy, but also anterior and posterior repair. And Terry's not here today, but he really did help throughout the project. And so we have really good sensitivity, specificity, positive predictive value, and negative predictive value. So for vaginal hysterectomy, for example, the pass-fail score is 180 out of a total of 400. So that's what you need to achieve to be a proficient vaginal hysterectomy surgeon. And you can see that the sensitivity, so 92% of the people who are proficient passed, 100% of the people who are novice failed. So those are pretty good numbers for these models. Now, remember, what really counts here is, are these models good enough to improve skill in the actual operating room? And so this was really our primary objective here through this randomized control trial, to investigate whether these procedure-specific skills translated into improved, and what we used for that was global rating scale of surgical skill. It's a very widely used scale of assessing surgical skill in operating residents who are supervised, and it involves things like forward progression, forward flow, or use of instruments, or knowledge of steps, and so on. So it's a scale that is used for any procedure, not just hysterectomy or not just laparoscopy. So we're looking at these 3 procedures, and our secondary goals were also to investigate whether these skills acquired in a lab compared to usual training resulted in improved procedural knowledge of the steps. Did they know the steps a little bit better? Their overall, the overall impression of competence and global rating scale, procedural steps knowledge, and impression of competence were rated by the attending who was supervising, who's blinding to group allocation. And the residents themselves also had a self-confidence score, which is a validated scale, as well as overall satisfaction. So this was a trial that ran between 2012 and 2023, unfortunately through COVID, which slowed us down significantly. It involved junior gynecology residents at 3 university centers. So by junior, we meant fewer than 5 supervised index procedures. They were recruited, and then they did a pretest of baseline knowledge, followed by being randomized to intervention or control. So in the intervention, again, they did the didactic modules, which were procedure specific, and they did a post-test. If they passed that, they went on to try their skills on the low-fidelity simulation, which was an individualized practice with someone like myself at each center. And then they, the actual person supervising would determine, yes, you're ready, or no, you're not ready, you need to practice more. There's an element of practice at home, which was unsupervised and left to the individual resident. And then they would go on within 3 months to have to be rated during a procedure in the real operating room on real patients as a supervised procedure. And the control just had usual training, which typically involves a supervised procedure, performing parts of it, reading around the case, and so on. We had an a priori sample size determination, and again, we used a global rating scale, a self-confidence scale, procedure-specific steps, competence, an overall question of competence and satisfaction questions. This is a resident with a very small uterus that she has just removed. She's very proud of it. She came through our study at some point. And this is our concert flow diagram. So we started out with a lot of residents assessed for eligibility. They're mostly female because that's the reality of OBGYN residencies in Canada and elsewhere. And they were of mean age 28. And then we ended up with 26 analyzed in the intervention group and 29 analyzed in the control group. And so we did show some improvement in global rating scale, and this was overall. And if you notice on the left-hand side, you've got all residents, but on the right-hand side, you can see PGY 1, 2, and 3. So first year, second year, and third year residents for both global rating scale and self-confidence rating scale. So you can see that the improvements that are significant are mainly due to the most junior residents going through and learning these procedures. The surgical performance scale did not demonstrate an improvement. I honestly don't think that was sensitive enough to differentiate between these residents. And then the satisfaction scale, for some reason, they were mostly satisfied with the most complex procedure training, which was the vaginal hysterectomy. And in parallel, I mean, this would be just another talk on self-confidence alone, but essentially we showed through these nicely executed violin plots that we were able to almost cluster confidence a little bit tighter around the mean, just because it's difficult for surgical educators who are supervising a resident to also deal with their confidence issues while operating. So we're trying to optimize self-confidence. We, again, don't want overconfident surgeons, and we don't want underconfident surgeons, because it's just very difficult to move them along and ensure forward progression. And so what this did quite nicely was really improve their self-confidence in an optimal way, so not in an inappropriate way. So we need to be all these things, right? As surgical educators, we need to be preceptors, so teaching procedures, proctors to evaluate them through summative assessment. mentors, to emulate or give, show them a model of what they could become, and coaches, for sort of daily skill training. And that, I am convinced, needs to be conducted in a safe and well-supervised environment, and in an individualized way, and with multiple opportunities of assessment, including formative and summative. And through this, it also emerged that we really need to think a little bit more about how to train frontline clinicians. Because it took me 10 years to gather these sort of surgical education skills. I don't have any formal educational degree, and most of us don't. When we're clinical OB-GYNs, we don't really know how to teach, and we need to spend more time in every surgical profession training frontline clinicians to teach. So this is really where it all came together this year, where the local residency program decided to implement this into regular residency training. For the first time, every resident going through at a PGY2 level has to do this training to be able to operate. And we had to build more models and see what they cost and provide some guidance, because ultimately we're hoping that this will be adopted across Canada, hopefully, and maybe even broader. So if you can think back to that Miyazaki model of, US dollars, 6,700 plus parts, it took us some time to manufacture the models, and, the person who supervised is here in the room. So Nikki is here with us. And so she took about 7 hours to supervise a volunteer junior engineer who volunteered her time for 16 hours to build these models. So she built wooden models with 3 anterior, 3 posterior, and 3 vaginal hysterectomy models. We then had to purchase silicone skin for all these. And then we had some 3D printed models that the residents each took home to practice on. And we've got some cost there for filament, silicone skin, and the 3D printer was complimentary. And we came up with this cost of per one wood model, $34. And the cost is not there for the 3D printed model, but it's probably lower. And then for proctoring, so proctoring just means evaluating whether they passed or not. So they had the didactic multiple choice question test, which the proctor had to be there for, as well as the practical portion where they had to be, again, they had to do the model and be timed and scored with errors. So that was 3 hours and 8 hours, so 11 hours total. And that was for a total of 8 residents in PGY2. So the initial total, if you're starting from scratch without models, is $2,900 per year. Moving forward, now we have the models, so they can be reused. It's $2,000, and per resident, it's somewhere around 261 Canadian dollars. So much more affordable than the Miyazaki model. So I just wanted to take a moment to acknowledge our young engineers. This is Miss Gabrielle Willette, and you can see she's in grade 12 and she's going into engineering next year. And I love the picture in the middle. And she was supervised by her teacher, Jamie Girouard, they spent a long time on these models, and they are absolutely amazing. And then Vincent, he's actually my son. He's sitting in the audience, so you can ask him about his 3D printing skills. We do own a 3D printer, so that's why that wasn't included in the cost. So he tinkered away with his models and made one for each resident, and that took him, I don't know how long. I still have to ask him, but he uses his model, Tinkercad to actually design and make it exactly to specific sort of dimensions. So if you have any questions, please feel free to ask afterwards. So time for implementation, there were, again, 8 residents at the PGY2 level. They were all novice. There were 4 attending staff preceptors for the 2 practice sessions, and then 1 proctor for administration of didactic modules and practical exams with the scoring. And we calculated that in total, it took approximately 10 hours per resident to go through, and plus the extra practice at home, which we're not too sure how long they spent, but we did ask them afterwards. So these are some pictures from our workshops. These are the models in action. This is the anterior and posterior repair model and a completed model on the right-hand side. And again, you can see and this is the vaginal hysterectomy model with all the instruments and sutures needed. And at the end, they get a certificate, and they can show the certificate, and hopefully that will improve their exposure to surgical procedures. They can show this to whoever is doubting their skills in that particular moment, and hopefully they'll be able to do more in the actual operating room. I have to thank Nikki in particular because she's been the heart and soul of this program from the very beginning. And you know, actually Vincent was 3 years old, so if he stands up and see, you can see how tall he is now. You know, you can imagine just how much went in this project and for how long. So in terms of satisfaction, we're almost there. You've got satisfaction is essentially out of 5 and several questions, and a total of 40. The 8 learners didn't all give answers to these questions, but essentially they like these models. They wanted them back. We did get some useful feedback. So for example, with the 3D models they took at home, they didn't really have instruments. So we're hoping to source some instruments for them to take home, perhaps plastic instruments that they can easily practice with. So in majority, they are unanimously happy with the appropriateness of level, usefulness of the videos, the improvement in knowledge and skills based on the curriculum by subjective self-evaluation. They love the instructors, which they rated at 4.9 on 5. And which was really interesting to me, time spent in home practice between the practical session and the practical exam, which was about a month. Some didn't do them at all, and some actually practiced 2 hours per week per model. So you can see the incredible range of these, you know, residents who are practicing from nothing to 2 hours per model. So that's 2 models, so 4 hours per week. And then we had some suggestions for improvement. And again, you see the personality styles reflected there. Some wanted more time for didactic portions and individual versus group learning. Some wanted more high fidelity models. And of course, we can't provide that because we don't know if they work. This, we know it works, and we're not going to change at this point in time. Somebody else can spend another 15 years and, you know, work on that Miyazaki model to prove that that's the best one. It won't be me. And that's all I had. I really wanted to thank everybody again, Gabrielle, Vincent, and Nikki, and a whole bunch of other people who really supported us through this project. It's really, truly a team effort, and I wanted to single out the program as well, but extremely accommodating and supportive. The other sites, so Calgary and Alberta, and of course, statistical support from both Terry and Joel throughout this. I'm sure Joel doesn't even remember how we all set out, you know, it was so long ago, but he did help a lot throughout. And also the participating residents and fellows, and last but not least, the Royal College for supporting all of this. That's all I've got.